Good afternoon. Hi.
Good afternoon.
Thank you so much for accepting and being here with us on the ongoing series on the trends and outlook of healthcare industry. So you had a phenomenal career, more than 30 years, and a large part of that has been associated with life sciences and healthcare, right? I brought Sunil with being is managing director in the Hyderabad office, so we would maybe get into the Q&A. But first, would love to hear from you on your journey so far.
Firstly, thank you, Vishal and Sunil and Protivity for inviting me to participate in this conversation. I'm told that you're having a similar set of conversations with a bunch of stakeholders, so delighted to be part of it. And also welcome to our city of Hyderabad. It is more than 400 years old. And why we're famous for biryani, there's a lot Hyderabad offers, especially in life sciences. That's why we are based here in terms of pharmaceuticals and healthcare. So thanks a lot for having me here. In terms of my journey, I'm going to try my best to keep it as short as possible. Yeah, I'd love to spend more time talking about InvAscent and what we do and why we exist and what we've done. Maybe I'll spend more time on the healthcare, but I'll leave the pharma for another day because, so I used to go to visit my mom who lives back then she was living in a small town. And this was 2004-05, right? I mean, decades after India got independence. And I'd already spent like 13 years in the US, right? So I was able to see India through a different set of lenses. Yeah. And what struck me was even in this day and age, how come there's no good quality secondary or tertiary care 2 hours outside a metro? So if you drive 2 hours out of Hyderabad, it's hardly any, back then there's hardly any good quality. So I began to kind of just think about it and double click on that question, kept asking why. And so I concluded that, look, the general hospital model is a colonial legacy actually, because back then they had teaching colleges, medical colleges, and they have to be attached to a medical hospital, right? And by definition, medical hospital, which is attached to a teaching college, has to have multiple specialties under the roof, because the college cannot say, no, we only teach heart or we only teach lungs, right? You have to teach the whole anatomy. And later when private sector, then when government started scaling up, so back then, several decades after independence, government was the primary healthcare provider in India, right? So when government started building healthcare infrastructure, they built medical colleges and had general hospitals attached to them, right? And then when they liberalized healthcare and encouraged private investment in the 80s, most of the doctors who were entrepreneurs back then were trained in that same environment of a general hospital and a teaching college. So they replicated that model. So we therefore saw the emergence of a lot of large private general hospitals. And most of them were located in dense urban areas, densely populated, right? Because that's where the social infrastructure was. So that's the reason why even in 2004, one couldn't find, modern, if you will, if I can use that term, secondary and tertiary care, like cancer, right, or neurosurgery or cardiac cath labs. Because to build a large general hospital in a tier 1 city back then or district headquarters was financially not viable and also difficult to attract doctors and nurses to work there, super specialists. You need scale on so on for, right? One had to travel great distances, and that was a very inconvenient and also disadvantage. But the unit economics of healthcare delivery to a large extent is determined by the choices the provider makes in terms of size of the hospital and the various specialties that will be housed inside the hospital, because the capex drives break-even time and the footprint drives variable expenses, overheads, which then drives margins and cash flows, which then determines the catchment area population. So all of that was feeding it. So I asked myself, why does, for example, ophthalmology need to be inside a general hospital? If somebody needs to get a cataract done, why do they need to go to a general hospital? Or if a woman wants to give birth to a child, why does she need to go to a hospital full of sick people? Or if a couple wants to start a family and they need help with IVF, why would they need to go wait in a lobby of a hospital full of sick people? Right? So if we keep asking that question, many super specialties, the logic for housing many super specialties was the one roof was just very weak. So the idea then was, look, if we can focus on one of the specialties, it costs a lot less, and we can then build much faster, scale faster, bring it closer to where patients lives.
Yeah.
So one of the principles that was, like in automobiles, for example, you hear of total cost of ownership, right? Correct. Here, the total cost of treatment in India is the cost of undergoing the treatment in the hospital, but the whole family, culturally, the whole family goes to the city, boarding, lodging, lost wages, travel, all of that stuff is the total cost of treatment. So to compress total cost of treatment, one way to approach it, we thought, was asset light, smaller footprint, closer to where the patients are. Anyway, there's a bunch of other things that were going on. I decided, look, I'll quit McKinsey and just start a PE firm that will actually focus on life sciences. But pharma being the largest segment of that universe, we always ended up deploying about half the fund in pharma. But that's for a different day. We'll chat about it. Today it's about healthcare, so I think about healthcare. But our first investment from the first fund way back in March 2007 was Healthcare Global. Right. And so going in, the investment thesis was focus on one of the specialties, right? It's a small business, first investment. It's of course now listed. But at HCG, and I give credit to the founder, Dr. Ajay Kumar, we actually sort of literally with him and his team wrote the playbook on hub and spoke networks. Because to set up fully equipped hospitals, right, was prohibitively expensive. So we had Bangalore, for example, as a hub in the south. So we had CyberKnife there. There was only 3 or 4 in Asia at the time. Right. But then we had, in Mysore, E-Road, then we had in Vijayawada. Similarly, we had a hub in Delhi. So the idea was take the more complicated cases to the hub and treat the ones which are less common. 8 out of 10 don't need to be treated in the hub, right?
That's satellite.
And since then, we've done ophthalmology twice, Dr. Agarwals, which is now listed. We have Sharpside, which is now in North India. We've done orthopedics. We've done, actually, one of the investments I'm most proud of is Ankura Hospitals out here in Hyderabad. The PD Stars this year. It's the second largest neonatal and pediatric ICU network in India capacity, right? And since we invested, lives of about 30,000 babies has been saved, because you have Ankura in Khammam, you have Ankura in Vijayawada, you have Ankura in Tirupati. In those places, if there was a premature delivery or a high-risk delivery, the odds of the baby and the mother surviving were very slim. But now the odds are much higher, right?
And when you invested in Ankura, how many hospitals were there?
Back then, they only had, I want to say they had 2 in Hyderabad, one in Kukatpalli and one in, I think, Madilaguda, or Medipadu.
And now, how many hospitals?
So now we have about 1,500 beds. So back then, I think we had like 200. So we have 1,500 beds across 14 locations. Fantastic. And we're still going, by the way. I mean, we haven't stopped. It's just, phase 1 of the journey completed. We have lots more. But anyway, it was a very long answer to your first question. So let me pause there.
Phenomenal, sure. I think the thing that strikes is after 10, 12 years bringing in consulting and abroad, just thinking that having that vision of investing in healthcare, even if it was through a PE fund, I think it's phenomenal. I have more questions on that, but I think I'll just hold on to our next conversation. But So since you, Hari, so you said 2006 or maybe early 2000s is when you returned back to India, right? So you've seen the healthcare industry over the last 2 decades. What sort of trends have you witnessed in terms of both accessibility, affordability in the healthcare industry over the last 2 decades?
I think there are 3 or 4 big macro ones, and I'm deliberately not going to mention technology because it's still early days, uh, like AI and things like that. But first is the most obvious one, right? Huge tailwind in terms of healthcare spend in India. This is almost 1.6% a few years ago. Now it's about 2.5%. And that's because of 2 reasons. One, household incomes themselves have grown substantially. And so more and more people are now willing to spend a bigger percentage of their household earnings on healthcare. And awareness of treatment options, variety of reasons. So the spend has gone up. Government also has been very active. Actually, there's some data I'd shown my investors over the last 2 decades. It's the stark.
Yeah.
Government has very, very quietly gone from being a provider of healthcare to a payer of healthcare, right? If you look at the number of healthcare locations which are government operated and private, it's like government has gone this way and private has gone the opposite way. And now government insures or covers almost 30% of India's population through various insurance schemes, central and state. There's another about, well, I would say 25, so about quarter. There's another about 10%, 11%, which is privately insured. So
Do you think that's intentional moving towards what US does, or
no, I don't think they're copying any country. It's just that
that's the more practical approach, right?
the government has withdrawn because they were not able to staff and run their hospitals. They were not able to operate expensive equipment to be set installed, right? And they felt that, rather than have a sick populace, if it is more efficient to pay for someone who's delivering the care more efficient, and the clinical outcomes are much better.
Yeah.
Right. Customer satisfaction was much higher. I think it was a very pragmatic thing to do. There are a lot of naysayers who feel like, look, healthcare should not have been abandoned by the government. But except for LV Prasad Eye Institute, can you point to me one not-for-profit, world-class, not-for-profit healthcare provider in India? LV Prasad is world-class. Ophthalmologies. How many are there? LV Prasad has over 100 locations. How many AIMS are there in India right now? For a population, how many AIMS are there? Right.
So it's more of a PPP model indirectly, right? Where government should stand back and allow more private players to come up and indirectly fund it through this model.
You could, that's a roundabout way of putting it, but yes, I think they concluded that important thing is for the citizens to get good care, right? And if the private sector is able to do that, they're okay with making space for them, instead of crowding them out.
And then also focus, and the specialized services can be given by the so-called specialized peak, and then they can actually get onto the other side of it.
Yeah.
So any specific segments within healthcare?
So that was just the first trend, madam.
Okay, yeah, please.
Right. So that was growing spend. The second one is people and patients are moving closer to where the care is being delivered, right? So if you look at so people call it urbanization, but roughly, if you take metros, tier 1 cities, tier 2 cities, it's almost double. From 300 million people a few years ago, now we have 600 million people, right? Close to half India's current population living in what are described as urban areas. And therefore, they're able to now access secondary care, tertiary care.
Yeah.
As opposed to in the past where connectivity is poor, that drive for 4, 5, 6, several hours, a lot of hardship, a lot of information asymmetry, right? So that's one. The third one is what I mentioned in terms of information. Because of all of these smartphones and Facebook and WhatsApp and all of that, the information asymmetry has shrunk dramatically. Patients are more aware of their options, where they can go to get treated and so on and so forth. And last, of course, is my favorite, which I spent a lot of time on, which is the emergence of these networks or chains of super specialty focused healthcare providers, right? One or two, like cancer, ophthalmology, onboard nephrology, right? Intensive care. And now we've seen, so they've scaled. Now, last year, about 76,000 crores of worth healthcare delivery was provided through these networks, super specialty focused. Big industries grow. Yeah. So the proof of concept has been established. They've scaled. And there's a thirst in the public markets for profitable, well-run healthcare providers. Yeah, right. And large financial sponsors, PE funds, can now see how they can invest and exit these in the via IPO or a strategic scale. Unit economics are favorable. Yes. And they therefore are more open to investing. Literally, when I started InvAscent and launched Fund 1, large PE would they would not touch these kind of businesses with a barge pole because they were convinced that these could sell.
So the number of control deals have gone up so much,
right? Because eventually these are all going to be listed. Correct. So because these are, but what you're talking about though are the large multi-specialty. But even the single specialty, Dr. Agarwal's listing was a big milestone in my opinion, right, for single specialty. So with about $4 billion in the last few years, over $4 billion was invested in building out this single specialty, super specialty networks. And with that, we are now seeing modern care diffuse down into even past tier 1 to even tier 2 cities. Yeah. Right. And social infrastructure over the last 2 decades has improved. So it's easier to attract doctors, nurses, connectivity, more airports, better roads. So people are able to travel back and forth.
Yeah.
As a result of all of this, I would say that modern healthcare is spread deeper into where most of India lives, not in the 6 cities.
Correct. Yeah. So also this is a big threat.
Where the patients are.
Yeah. Interesting. And within these segments, you've got hospitals. Within hospitals, you've got multi-speciality, you've got single speciality, and then you've got diagnostic chains, and then you've got edtechs. So any specific segment that you've seen growing exponentially or more than some of the others?
I'm asked this question often. Vishal, in India, healthcare is not a demand side. Yeah. So we already have enough. It's a supply side issue. We do not have enough doctors.
How fast we
don't have that. Because at the end of the day, we're talking about treating a person, right? So clinical outcome, quality clinical outcome is very important. One can build very modern hospital with the best equipment, but the doctors, the nurses, the paramedics, the equipment technician, they ultimately determine the clinical outcome.
Yeah.
We don't have, for a variety of reasons, which I don't want to go into this chat.
Oh, somebody was telling me, just don't have enough. Yeah. And you don't have accredited in hospitals also, right? Only very, very small portion of the hospitals are also accredited.
Because to accredit a hospital, they need to have certain bare minimum level of skill, expertise, and processes. Right? So it's a supply side issue.
There's scope for all the segments to grow. Yeah, as long as we have enough resources, it's how fast we can grow.
Yes. I mean, when we invested in Sharpside, I think this is 3 years ago, just before COVID, they were predominantly NCR, but they've grown quite a bit. We did the math, and just parts of Uttar Pradesh, not the entire state, parts of Uttar Pradesh close to NCR. We're looking at the catchment area, right? Parts of Bihar, and then some parts of northern part of NCR, etc. Just in that region alone, there was a backlog of 1 million cataract cases. Now, backlog. This is pre-COVID. Since then, that backlog has only increased. And we've been opening centers as fast as we could. But the rate limiting step is finding good surgeons, nurses, right? So it's not a demand side bulb. Yes. And along with that, this will fuel demand for medicines used in ophthalmology, devices like intraocular lenses, sutures, everything, right? So we think that all of these are attractive.
So, you speaking to the CEO Indranil was here earlier today for the Apex Kidney Care, and he spoke about nephrologists. You only have 3,000 nephrologists in the country. So, from your perspective, are you using the doctors who moving out of the country, or is it that there are not enough seats that are?
Yeah, the supply itself, now they're ramped up, but there's a lead time, right? I mean, it takes time for the supply to catch up. And medicine is a complicated science. I mean, you can't just pump them out like on an annual basis. It takes to produce a specialist, it takes close to 8 years. Yeah. You have MBBS and then specialization, and then they have the apprentice for 1 or 2 years before they can then be independently. Yeah, sure, it takes time.
Interesting. So, and from as an investor, Hari, what are the 2 or 3 important aspects? Obviously, there is the whole thing about scalability, from leaving the fans apart. What would be the 2 or 3 key considerations when you look at an asset to invest? Whether you call it from a diligence perspective or whether you call it from a overall comfort perspective. Is this the right business or the right promoter, for example, to partner with?
Yeah, so Vishal, if I may, I'd like to use a different word to describe where we're going to invest, right? So we prefer to think of them as healthcare providers as opposed to a business. It might sound a bit corny, but that's exactly why I want to emphasize. And because here we have people who are being treated.
Yes.
The whole objective is, how do we get modern healthcare closer to make it more affordable and make it more accessible to the people who live in India, right? That's the overall objective, while earning a commercial return. Definitely, we're not a non-profit, we're not an impact fund. And for that, I've already explained to you how a for-profit model is the one that basically is able to grow compared to non-profit. So for that, the team is extremely important, and we prefer physician-led healthcare providers, right? Culturally in India, it's easier for a physician leader to direct and guide other physicians, right? Because a healthcare provider has to, a lot of times, take decisions, yes, to make sure that the organization is financially viable. Whether it is, prescribing from a pre-approved pharmacy or standardized care protocols, standard operating procedures, network-wide referrals, leveraging expertise in different pockets of the network. There's just a whole host of reasons why a physician leader, we feel, is better equipped to sort of get everybody to go together in one direction. Yeah. Because in general, I mean, no offense to corporate doctors in India, but in general, I mean, I doubt if they'd be excited at taking direction from an MBA. So now that we have laid out the importance of the physician leader, the next thing we look for is ethics and integrity. That it is extremely important, especially in healthcare, that the healthcare provider conducts itself with ethics and integrity, which will ensure quality and clinical outcomes. And the patient shouldn't be completely bankrupt when they leave the hospital.
Right.
Right. And therefore, the importance of the top team. Yeah. And that for us, if I have to rank 1 through 10, 1 through 9 will be that. Yeah. Then, of course, we'll then look at the track record of that healthcare provider in terms of what is the clinical outcome that they have demonstrated in their specialty over the years. and where are the vulnerabilities, where are the strengths. We have a very, very detailed audit that we conduct, and then there's a periodic audit. But a lot of it is aimed at understanding the underlying processes that ensure
Clinical outcome.
good quality anywhere in the network, right? Because ultimately, it's the brand that is going to bring the footfalls. There's word of mouth, but underneath the word of mouth, there's brand.
Yeah.
So people should feel like, hey, if we go to so and so hospital anywhere in India, we'll get good treatment because they're known for good treatment,
Right.
at a fair value, right?
Right.
So I cannot overemphasize the importance of the leadership team, which is anchored by the founding physicians, 1, 2, 3, I don't know how many, it depends.
No, good. On one side, you mentioned a very interesting point about the backlog on the cataracts in one of the states. And on the other side, we also see digital tech, AI, and tech-enabled delivery, that taking the future of the healthcare delivery as well. So how do you see that we catching up as a country on both sides of the table?
That's a fantastic question, Sunil. Thanks for that. See, the thing is, it's interesting because in any process, right, if there's multiple unit operations, generally the slowest one becomes the bottleneck. Now, what AI, at this stage at least, what AI and all tools have done is they've improved diagnosis to a large extent, right? They have contributed to acceleration of diagnostic capacity. We can diagnose more people with cataract faster. We don't have to visit an ophthalmologist, right? The specificity, sensitivity of these tests has improved a lot. So the bottleneck now is the actual surgery itself, right? At some point, hopefully, we'll have enough capacity to ensure that people don't have to wait for too long. But India is much better compared to European countries where it's socialized medicine. People have to wait for months sometimes for an operation. Like here, at least, all people have to do is take the inconvenience of going to another nearby city where they don't have to wait that long to get operated by a top specialist. But so AI has helped in that way, diagnosis. Two, it's also helped in preventive care. It's able to measure different parameters, vitals, proactively alert the individual. So that it's helping a lot. And three, it's also helped a lot in monitoring the patient's health, like especially recovering after surgery, whether in ICU or in the recovery room. There's a lot of tools that are being deployed now. So that's playing a big role. And lastly, AI. We've actually invested in a agentic AI company, which is disruptive. Well, the disrupt is a very abused word, so I would please delete that. But which is really changing the revenue cycle management in healthcare because a lot of healthcare providers wait to get reimbursed for the work they've done for treatment they've administered to a patient who's insured. There's a lot of back and forth between the insurance company, the third-party administrator, and the hospital. And a lot of that has now, gone away because it's all being done by agentic AI grips, right? So that's helped patients get discharged faster. That's helped hospitals come as their working capital requirement. So a lot of that is happening. So technology right now is having impact in the periphery. Now going forward, how is it going to help address the bottleneck? Because at some point in this, healthcare is a very complex system. So the bottleneck will keep moving. Right, diagnosis is not a bottleneck. The actual surgery care is about. Maybe it'll help in addressing that also. We don't know.
Maybe not AI, but some form of technology innovation should have.
Yeah, because those tools. So if a surgeon can perform 6 procedures, maybe with the help of some of these tools, maybe the productivity can improve and they can do 8 or 10 procedures, right, in a given period of time. So I don't know. We'll have to wait and see.
Even the patient expectations and consumerization are really influencing the overall the landscape. How do you look at that? How do you see that for the future? Customizing.
Like I said, look, information asymmetry has shrunk, right? So people are getting more and more savvy about where to go for treatment, who to see the treatment from, which surgeon, which hospital, which basically means hospitals, healthcare providers will need to really pay attention to customer experience, patient experience, what they're charging, the value they're delivering. Um, you know, that's there for sure. But taking it one step further, I think what's happening is a lot of information is now being collected by insurance companies, by the government, right, on procedures, costs of procedures, outcomes. At some point now, with AI tools maturing, the opacity in terms of which hospital is delivering what quality care at what price will disappear, right? There will be more or less a lot of transparency. So hospitals will need to really hash up phenomenal operations at the back end, yeah, clinical operations, like that inefficiency which used to go unnoticed, only a few patients would experience it, would now be laid bare. And what they can charge, the ability to price discriminate will also diminish.
Okay.
And at some point, if these insurance companies or governments choose to turn all this data into ratings and they start giving platinum, gold, then bronze and all game over for them, right? And believe me, by the way, these ratings, it's not necessary that only a large hospital will get it, right? You could have smaller hospitals who are really good at what they do and they're delivering excellent clinical outcomes at good value. They could also get them. So it's not like a scale will automatically get the rating. I don't know if I answered your question.
Oh, no, you did. I think it's back down.
Yeah. So over the last few weeks, Hari, and we've been talking to a lot of founders also, and some of the B funds. So we've been seeing a consistent message about increased M&A activity happening in different parts of the entire sector, healthcare, right? And obviously, there's consolidation that somebody is doing because of consolidation, achieving scale, is moving, growing faster. Any thoughts that you have in terms of this whole M&A activity in the healthcare industry? I'm sure that I think that
Look, multiple factors actually have converged. One, providing healthcare in metros has become very competitive with a lot of capacity, and it's not as easy as it was a decade or 2 decades ago. So providers are now sensing the demand for healthcare outside the affordability, the ability to pay for all that. They want to expand out of the metros. And like I alluded to before, capital providers like, private equity funds or other sources of capital are comfortable backing these healthcare providers' expansion beyond the metros, right? So that's from the demand side.
Yeah.
Well, the supply side, but just because I want to acquire doesn't mean that I can, right? There need to be a willing seller. Now, we have seeing willing sellers in these tier 1, tier 2 cities because the whole generation has aged.
yeah,
Of the whole generation of doctors has aged. And in some cases, their children are not interested. Either they have not studied medicine or they're not interested in managing the hospitals their parents have created for a variety of reasons. Right? They want to pursue other careers. So a lot of these physician-owned and physician-operated hospitals, which are smaller in size, located in tier 1, tier 2 cities, are now contemplating selling out to healthcare providers from other parts of the state or India, larger, who want to grow. It's, in a way, though, it's faster to grow via a brownfield strategy, right? Because, buy land, that takes forever, build, that takes forever, get permissions, blah, blah, blah. Then, get it all commissioned, then staff it. I mean, it just takes forever. It's faster to refurbish an existing location, make sure it meets fire safety norms and other clinical norms, and beef up, strengthen processes. It takes less time.
Yeah, well, interestingly, you were speaking to Sachin a couple of days back, and he spoke about this whole acquisition strategy. And it is not necessarily they were acquiring hospitals, they were also looking at acquiring buildings that were previously being operated as hotels. It's easy to convert a hotel to a hospital here. So interesting. So a lot of these acquisitions that are happening, how difficult or how easy is it to integrate?
It's a great question. It is tough.
Yeah.
And the tough part is the cultural assimilation, right? Because physician-owned, physician-operated hospitals have a different culture. It all revolves around the founding team, 1, 2, 3 physicians. There is a lot of deference, like, and if standardized set of processes, they're viewed suspiciously initially. Mindsets, behaviors takes a long time to change them, and then at the end of the day, the doctors, so they need to be sort of, I would say, need to approach changing their mindset behaviors differently. You cannot have a diktat coming down from corporate headquarters. And some of the patients also are very loyal to that particular physician. So there's just a lot of softer issues that need to be addressed. Yeah, not easy. Very difficult.
So it takes a lot of planning to work on those things.
And it takes an experienced team, because people who have done a few understand the pitfalls, understand the approaches, the challenges, what works, what doesn't work. And if someone who has never done this before, wants to raise a lot of capital to go acquire, and in the US they call it roll up. Yes, it's not easy here. In fact, even in the US, if you actually think about it, a lot of physician practice roll-ups weren't very successful initially.
Yeah.
Even a geography would be playing a role in that particular thing, like the cultural sensitivity of geography.
Yes, absolutely.
Samara has been doing that or you speaking to Abhishek earlier, and so they've done that reasonably well and very low at some of the other investments that they're. Okay, so Hari, what is the in terms of your investments? I think InvAscent would have done what, close 30 investments?
35 that he lost count, but I think 35.
I think I couldn't collect. So 35 investments you've done over the last 18, 30 years.
Yeah.
Right? What has really worked for InvAscent? Again, it's a very general question, but if you may choose to answer that, the more important thing I want to know is how has InvAscent created value with your portfolio company other than capital?
So, the start you'd asked me a question about my journey, and I said I love something without, so maybe I should touch on one. So, one of the insights I had when I conceptualized InvAscent was how most of the demand for generic pharmaceuticals and for healthcare services in India was actually being filled by SMEs, right? Small and mid-sized enterprises. Because even in the large generic companies' supply chains, like you take Dr. Reddy Labs or Sun Pharma, many of the medicines they export or sell in India actually are sourced from USFDA approved or EU GMP approved facilities which are owned by SMEs, small mid-sized enterprises. So these SMEs have two issues. One is access to capital, because banks in India don't lend beyond a certain limit, right? And in pharma and hospitals, sometimes the gestation period is quite long. And two, they have a talent issue. The smart ones want to go work for productivity. Right? The SMEs are struggling to attract smart individuals to help them grow. Right? So the idea that was that we do private equity old-fashioned way, which is not like rely on leverage and all of that, right? Which is all newfangled. The old-fashioned way of rolling up our sleeves and actually being a true partner, and work with the promoters of these SMEs in improving operation efficiency, in strategy, in strengthening the organization, putting in place decision-making processes. Because generally speaking, there's a bunch of criteria we use in terms of whether it's an attractive investment. But one of the things we find all the time is that business is built for the scale that they are currently operating in. Right? It's not built for 10 years scale 10 years from now. Yeah. So we want to transform the organization in partnership with the promoter so that it can actually function really well 10 years from now if its growth aspirations are fulfilled, right? Right. So you're doing 100 crores now, want to be 1,000 crores. This team should be able to manage 1,000 crores business without the wheels coming off. No. So because the promoter into that level. Yeah, because a promoter, we think there are three very important activities. One is capital allocation. Right? What do we spend the money on? Which products to develop for which market? How much capacity to put in place? What kind of capacity? There's just a lot of so really successful business people, if you really think about it, they're very good at capital allocation. Right. Right. Secondly, a very important role they play is in building their team, their organization.
Yeah.
Identifying the right people, right talent, motivating them, retaining them, right, getting them all to move in the same direction. That requires a lot of energy, a lot of skill. It's a very difficult task, right? And the third is being a responsible, making sure the enterprise is a responsible corporate citizen, right? Yeah. You're abiding by the local laws, regulation, not polluting the environment, abiding by all the labor laws, paying taxes, being good governance, right? Yes, this is a very important role for the promoter team. These are the three areas we actively partner with, right, and help them just make sure that they're comfortable playing those roles, that they're playing them effectively. So it's beyond just capital, because what the SMEs need is much more than just capital. Yeah.
You brought out an important point, Helene, about this balancing the pollution part of it, ensuring that the laws are abided by. But how do you balance off the social angle with the commercial angle of the returns in such a sensitive industry?
Well, like I said, it's actually, if you think about it, let's stick to healthcare because this interview is about. If you think about it, it makes total sense, right? How do you kickstart the virtuous cycle? If the healthcare provider delivers excellent quality clinical outcomes at a reasonable cost, word of mouth spreads, and they have more footfalls. And that attracts top talent, doctors, nurses. It ensures that the financial viability of that location, the unit economics works. And with the proceeds of that year's revenue and profit, it can be plowed back into creating even better infrastructure, even better patient experience, which then strengthens the word of mouth, which then gets more footfalls, right? It's a virtuous cycle. I mean, it's not rocket science. I mean, it's the right thing to do. If an individual has a good experience at a hospital, they will tell their friends, they will tell their relatives. If they have a bad experience, they will tell their friends even more assertively and loudly, right? So, so it's the right thing to do. There is no trade-off here. Anybody who's thinking it along those lines, oh no, we need to price gouge or this and that, that's very short-term thinking, very short-sighted. Right. Doesn't work. Long-term, it doesn't work.
Oh, very good. So maybe last thing from my side here.
How is it on Thai?
Yeah, almost done. So last thing from my side, Hari, you may choose to answer. You've had 35 investments. I'm sure half of them you would have exited, more than that.
Yeah, but we are one of the few fund managers in India who actually exited. You know what? I take that back. Sorry. We've made 38 investments and we've exited 19.
Wow, exactly 50%. Yeah. So any one or two exits that you're really proud of, not because of the returns, but also what you thought when you invested, how they were able to achieve more than what they did.
Look,
It's not in terms of financial numbers, but overall.
there's many I can think of, right? I mean, Gland Pharmaceuticals, which is now listed, right? That was the small business when we invested it. Healthcare Global, one of the largest cancer hospital networks. Dr. Agarwals Eye its market cap was 50 crores or something like that when we invested, right?
Yes, and right, I be fortune.
No, we did the Oasis. And then Neuland, which is another one that is, it's as a CDMO, a lot of people talk about it. And there are others which are not listed yet, but which I'm very, very fond of. Ankura Hospitals. Just when I think of all the parents who are holding their babies now, I mean, just give you so much satisfaction to think that, yeah. So that's one that at SharpSight, which is doing amazing things in North India in ophthalmology. I mean, there's just many. There's just a lot of them which I'm very proud of and very satisfied that we actually created. I would say I would like to believe we played a big role in
Make a difference to the
getting this concept of single specialty, focused super specialty networks, and moving closer to the patient. So all the investments were made in that. Another one that I'm really proud of is Symbiotec in Indore. When COVID happened, I don't know if you all remember, there was this medical phenomenon called cytokine storm. So anybody got the virus, because of the immune system's response, this releases a lot of cytokines and people were dying because the body couldn't be with it, right? And many of them survived because they were prescribed a steroid called methylprednisolone, and Symbiotec was producing it, in large quantities. Yeah, and it helped. So when you hear stories like that, you just feel it at affordable prices, right? So basically, when you hear stories like that, you just feel like, okay, we've made a difference.
yeah, particular.
Yeah.
Well, thank you so much, Hari. I think again, really impressed with your journey and the whole decision to start InvAscent, take it where it is today, make a difference to so many parts of the healthcare industry. We would love to hear more from you in the coming conversations. So again, we're glad to have you here, and really thank you for the time.
Thank you. Thanks for having me, and enjoyed the interaction. I hope you found it useful.
Absolutely.
Thank you.